once people have filtered.
Yeah, we can use.
Right.
Okay. Good morning, good evening, everybody. Ready to start? Good. So welcome to this webinar, which is aimed to introduce to civil society organization the international standards on the treatment of drug use disorder and the technical guide for countries on HIV prevention, treatment, and care for injecting drug user. Both were published jointly by UNODC and WHO. I would like to start with some housekeeping issues and remind you that this webinar is being recorded. The session is interpreted. I know for sure in Spanish, but we were waiting for the interpreters in French and Russian, so I hope it worked now. And the way to listen to another language than I would say the original is in English is by using the drop-down menu at the bottom of the screen titled Interpretation. And it's very important that you mute the audio channel named Original to avoid hearing the original audio and the interpretation at the same time. You can see the instruction in the chat box. Also, finally, don't use the chat box for question and answer because there is another box also down, which is meant for this purpose. Yes, I didn't introduce myself. So I'm Mirella Dummar-Frahi. I'm heading the Civil Society Unit in UNODC. Which is in the division of policy analysis and public affairs. And for those who are not familiar with the geography of UNODC, my colleague Giovanna and Monica and Fariba will be speaking later are in another division, the division of operations. So they are really the operation people. This webinar is part of a series that we have started together with the Vienna NGO Committee this year. We had one session on the drug convention in February, and last week was on drug prevention. And I'm pleased to open this webinar with Jamie, who shared the Vienna NGO Committee. I take the opportunity to thank him and all the colleagues, including Sarah, who is in the background, who has been trying to put together this session. And thank you to all for your interest and for joining. We had over 400 registrations, so this is wonderful. And I'm pleased that being the civil society unit, so this point of entry of the engagement between civil society and UNODC, we could do this kind, facilitate your participation in intergovernmental meeting like the CND, but also provide the training and workshop to build the capacity, or at least share our view and have your voice so that we can support better member states in the implementation of their commitments on drugs and crime. Okay, I think I will just before finishing, I would like to take the opportunity to thank our donor, Sweden, the United States, and the Russian Federation, who has continuously supported the UNODC civil society portfolio, and I pass the floor to Jamie for also a few introductory remarks. Jamie, the floor is yours.
Thank you, Mirella. Thank you so much. And yeah, just to repeat, really, thank you everyone for joining us today. We've got participants from all around the world, which is amazing. There's more than 160 of us on this webinar so far. And yeah, really appreciate your interest and your engagement in these events. We do now have the translation channels available for Spanish, Russian, and French. So you should see those, as Mirella said, using the interpretation button, which is at the bottom of your screen. And hopefully that all works. But if there's any problems, please let us know in the chat, and we can try our best to get those fixed. So yeah, so thank you, Mirella. My name is Jamie Bridge. I'm the chair of the Vienna NGO Committee on Drugs. And it's my pleasure to be here today and to welcome you all to this event today. As Mirella said, it's the third in a series, and hopefully, you know, not the last. Hopefully this is something that we can continue doing for our members and our civil society partners. So the previous events, we had one on the drug conventions and one on the standards on drug use prevention, and the recordings from those and the presentations from those can be found on our website, VNGOC.org. So I'd encourage you to go and have a look at those if you missed the events. And today we're going to be discussing the UNODC and WHO International Standards for Drug Treatment, which were finally released last year, as well as the UNODC, WHO and UNAIDS technical guidance on harm reduction. And I want to really thank our UNODC colleagues for joining us today to discuss these documents, but also to welcome and thank Devon from STAND in South Africa, who will be our selected civil society speaker today. Now, these normative documents from UNODC are really crucial weapons in our constant push as civil society. You know, we're always pushing for more evidence-based, more effective, more humane drug policies and services around the world. So as NGOs working in this field, it's really important for us to know about these standards and to know what the guidance says and what the evidence says, and then to use this guidance in reviewing our own work, as well as trying to hold our policymakers to account. And with that said, that's why we think these webinars are an important opportunity, and they're an opportunity to learn about the guidance that exists, but also to ask questions. And I do really encourage you to submit questions to our speakers today, and we'll have time for those at the end. So just quickly before we start, just to introduce, if you'll allow me time, just quickly to introduce the Vienna NGO Committee, just for those who may not know who we are. The VNGOC is a global committee. We represent around 300 organizations from all across the world. And our main job, our main role in this movement is to help coordinate and link civil society with the key UN processes and discussions. Most of our work, therefore, focuses on the UN Commission on Narcotic Drugs, which is actually going to be taking place next month online. For most civil society, it will be an online meeting. So as Mirella mentioned, please do ensure that you've picked your language, you've chosen your interpretation language, even if that is in English, because by selecting the English channel, if we do have some questions in another language, they will be translated for you. Please also use the chat box to introduce yourselves. You know, we'd love to know who you are and where you're coming from. So please do take some time just to say a few words to introduce yourself. It's great for people to see who else is on the call. But as Mirella said, please use the separate Q&A option. Again, you should see that at the bottom of your screen. And that's the way to submit a question to speakers. We can't really keep track of the chat. It moves so fast when there's this many people on a group. So the Q&A allows us to see the questions, and we'll take some at the end, but also our speakers may respond to some in writing as they come in, you know, if that's possible. So that's really it from my side. So without further delay, I'll hand over the floor to Giovanna Campello, who is the chief of UNODC's Prevention, Treatment and Rehabilitation section. Giovanna is a long-term friend of civil society and is, you know, a great colleague to have within UNODC, and also a driving force behind UNODC's international standards on prevention and on treatment. So with that said, Giovanna, over to you. Thank you very much.
I'm getting there. I'm just trying to mute myself. Okay, I'm fine. And now just give me one small second to open my presentation. Just looking a bit funny, and then to share my screen. Share screen. Host disabled participant screen sharing.
Sarah, can you make sure Giovanna has permission to share her screen?
Please.
Please.
Giovanna, you should have permission to share. It says so.
Yes, now it looks good.
Okay.
Thank you, Sarah.
Sorry if I did something wrong before. I think now it looks healthy on my side, also on yours. Okay. Well, thank you so much, and thank you for having me again. Obviously, it wasn't too bad on the prevention standard last time. And, but while I am here, I also want to acknowledge very much the work of the team of the Prevention, Treatment and Rehabilitation section, particularly of my colleague Anja Busse, who not only is leading the treatment efforts globally, but has prepared this presentation. And normally she would be here with you, but she's leading another training. And so given that I have the honor to coordinate the work of the entire section, you will have to do with me. And like last time, I particularly liked using Slido, which Jamie had to twist my arm a little bit to use, but I enjoyed it a lot, and especially the word clouds. So that's what I wanted to start with. And I mean, at the beginning, it's a really silly question that I want to pose, but please go to slido.com. You see there is a number that you can put in, which is #V794. You see it on the screen. And I have a silly question for you, but there will be more serious questions in later on. And I want to know which one of these standards, these normative documents that Jamie was talking about, are you more familiar with? The prevention one that I presented last time, and I totally expect you all to say the prevention, but also the treatment standard or the technical guide on HIV prevention that, of course, Monica and Fariba will talk more about in detail. Let's see. Only 5 people. In the meantime, I have learned to see how many people are voting. And I can see now we have 10 people. Come on, get your phone out and vote. And some people, thank you for your honesty and saying none. And I hope this will be a good introduction to some of these documents at least. And I can see that less people are familiar with the treatment standard, which is why I'm here. So thank you for this. The prevention standards, okay. Maybe I've been a bit too leading in posing my question, I guess. Let me move on and start telling you a little bit about the treatment standards, so that also the people that are a bit less familiar with them can start to know what there is in it and why I hope they are important. I have a few slides on the global situation, but maybe I will skip them also in the interest of time. I think we are all very aware of what is the situation with regard to drug use and drug use disorders. And I really think that the key is here, the fact that only 1 out of 8 people that need treatment have access to treatment, and the fact that this situation is even worse for women, where while 1 in 3 people who use drugs is a woman, only 1 in 5 people in treatment is a woman. And I've not been able to add a slide on this, but of course we know that this is even more so the case in the case of populations in prison settings, where we know that the prevalence of drug use disorders and other health issues is much higher than in the community, with less access to services, even if this is against international law. And rather than thinking about so much about the coverage, which is of course a very serious issue, for us, the standards really come out of concern of the quality of the treatment on offer. And the fact that many commonly used interventions do not follow scientific evidence. They are either ineffective or even harmful. And according to what we think, treatment really should be based in reality on scientific studies that shows effectiveness in terms of symptom reduction, so reduction of the use. And please see that I underlined the use reduction, because of course, while abstinence is the goal for those who want it, what we really are looking after is improvement, measurable improvement in the physical, psychological, social functioning, reduction in the symptom, and decrease the risk of negative health and social consequences. And the fact of the matter is that a lot of treatment that is on offer is not based on this scientific evidence, and worse, it is based on outright human rights violation in the name of drug treatment, and treatment that is compulsory, that is not voluntary, that subjects people to punishment, to cruel behavior, cruel and inhuman and degrading practices. And this is really behind our efforts to develop standards so that to help everybody see what good treatment looks like. And it's not, and really starting from that point of understanding that substance dependence is not a failure of will or a strength of character, but it's a medical issue. It's a health issue that needs a health response. And it's not like the member states don't know this, right? So even in 2009, which is by now quite some time ago, the member states had recognized that the lack of quality standards was really hindering any kind of progress in reducing drug use and drug use disorders. And so in following this, it is in 2009, we really started working together with our colleagues at the World Health Organization, and we launched a joint program on drug dependence treatment and care. And we really trying to promote effective and humane treatment for all people with drug use disorders. Really nothing less than would be expected for any other health issue. And I think this little drawing that you see in the middle is meant to portray Dr. Gilberto Gerra, who until recently was my boss, and under whose leadership really this program was created, and under whose leadership we developed many landmark publications, including in 2016, we had seen that the prevention standard had become a good reference point for member states. And so we thought maybe we should do something similar for the treatment standards. And we published a draft in 2016 that needed to be field tested. And this is what we have been doing in the last 4 years. But in the meantime, you can already see the member states were acknowledging the standards as a useful tool of reference to improve the quality of treatment, both in resolutions and in the UNGAS outcome document. The field testing was really extensive. It happened in 10 countries, and if you're interested, I have the list. Suffice to say for now that the countries were representing not only all the continents, but a higher development country, higher or lower social economic development, but also very different health system and drug control system. So really to have that perspective of visibility, and included thousands of service providers and people with lived experiences. And we managed, it was really an extensive work, and we managed to finalize it only last year. In reality, just before lockdown, we presented the final version, which is the one that I'm presenting to you today, at CNT last year. In terms of content, really, as I mentioned, the standards, we would really like that they are useful to support member states in developing and expanding drug treatment services and systems that are evidence-based and are based on scientific evidence on human rights, and thus are effective and ethical. And the entire standards are really guided by 7 principles that we had in reality published already 10 years ago, but they remain very valid. Treatment must be available, accessible, attractive, and appropriate. It should be based on ethical standards, on coordination between the criminal justice system and the health and the social services. Of course, should be based on scientific evidence, and above all, really respond to the scientific needs, to the specific need of the individual. And this, of course, as a corollary, means that there will need to be special treatment for groups that have particular needs. There are principles about good clinical governance, monitoring and evaluation, and about the need of having systems that are integrated, not with a service over here, a service over there, and people needing to run across services. And the system that is at the core of the standards is really based on public health principles. So offering the most effective, least invasive, and lowest cost intervention first, which basically means that most intervention that will be required are at lower level and for most people, because most people can be treated in the community, reserving the more complex, intensive, maybe residential services for the minority of complex cases. And as I was mentioning, in terms of public health principle, is also a matter of integration. And of course, the standards acknowledge that countries are very different from each other, and there will be different kinds of integrations. So maybe there is the one-stop shop, or some countries are organized around case management or around creating networks of community-based treatment services. Whatever your approach to integration, the important thing is that there is an approach to integration, and that services are all connected. So the standards also is organized around settings in which treatment can be delivered. And this is where I have maybe a little slide for you. And maybe we can create a nice cloud as to where you think should treatment take place. And look at the bracket. I say treatment, but of course I am referring to the entire spectrum of services that are needed to protect the health of people who use drugs and people with drug use disorder, and support their recovery if they so wish. So this, of course, includes healthcare, social protection, the HIV, the prevention, treatment, and care services of infectious diseases that Monica will talk about, rehabilitation and integration. And I can see some people are taking courage and really bringing in responses. Community is coming out strong. Where the people are, thank you. The one-stop shop, the general practice, family, very good. Let's have some more. And what I have learned from last time is that I've not been able to capture the after the presentation, there is the nice cloud goes. So I will try to take a print screen so that all of you can have the collective wisdom that is being shared at the moment. Come on, only 21, a little bit more. Don't be shy. All system, very good. Micro, meso, macro. I like the word the people are is getting bigger, and community is coming up in different guise. Okay, so let me take a screenshot. I don't think I managed, but whatever. Let's see, and let's move on. So thank you for participating, and I will try to get you the nice slide with the responses. For in the standards, we really talk about a continuum of care and of settings that have all different goals and different and can reach different treatment outcomes. Let's put it this way. And of course, the first one is community-based outreach, which is all about identifying and engaging target population, providing unconditional, no conditions, community-based services and interventions, and really that range of services that are needed to engage and protect the health of people. Basic support, safety, food, shelter, needle and syringe exchange programs, condom distribution, overdose prevention, of course, but also information education, services around infectious diseases, screening and brief intervention, and linkages to all the other services, including treatment services if the person so is motivated to enter. Another way of connecting the system is, of course, to connect to settings that are not specialized for the treatment of people with drug use disorders. Some people in the cloud were mentioned, families, schools, and really use these settings to identify people and provide brief intervention, and if there is a need and if there is a willingness, refer to specialized treatment. So you could do this in mental health services, in general hospitals, particularly in emergency services, but of course also in sexual health or infectious diseases clinics, in social services and welfare agencies. This is one of the places where the integration really comes into its own. Once somebody is motivated and needs treatment, of course, a lot of people can be taken care of by specialized treatment services that are outpatients. And really, you can provide a range of intervention to help stop or reduce drug use, minimize the health and social effects of drug use, but also identify and manage comorbid conditions. And this could be, physical, but also mental health. And generally, all of the services that are needed to improve that well-being and social functioning as part of a long-term support and recovery process. There will be some people that maybe in an acute phase might need specialized short-term inpatient treatment, and then can be referred back to outpatient treatment and really get back into their life. And then there will be, as I said, a minority that might need specialized long-term and residential treatment, maybe to really work on reducing the risk to returning to active drug use and maintaining abstinence, if that is the goal, facilitating rehabilitation and social integration. Maybe there is a need for vocational skills and learning those relapse prevention skills. So you can see that the standards really cover the entire spectrum of settings where treatment might be offered. But again, I'm talking about treatment, but what treatment interventions are we talking about really? And this is where maybe we can have another cloud and have your ideas as to the kind of, when I say treatment, what kind of interventions and modality you are thinking about, so that we can discuss them a little bit more. Can I count on your participation? Yes, medication-assisted treatment, thank you. One lonely person? Talk therapy, group and one-on-one, okay. Ooh, many at the same time. Counseling, safe supplies, hospitality. Cognitive behavioral treatment. Harm reduction. Counseling, OST, risk management. Hospitality. Motivational interviewing, safe supplies. Yeah. I'm waiting until we are like 25 or so. Yes. Wide range of services, including ART, anti-TB substitution therapy, and harm reduction. Thank you. That is very, that's very comprehensive. Okay, let me take a screenshot. And let me, oopsie. Oh, no. I've lost the presentation. Nah, here it is. Here it is. And so page down. Yes. So, oops, this is just a summary. I'm putting this in a range, starting from in the range of the complexity of the disorder, but this doesn't mean that one or the other is more important. So, for example, there is a part of the treatment services that is around screening with intervention and referral. That is particularly used in the non-specialized care settings. We have mentioned that, and particularly using, of course, the tools that have been developed and validated all around the world by the World Health Organization. There is a range of psychosocial interventions. Some of them were already mentioned in the cloud, cognitive behavioral therapy, for example, but also contingency management, community reinforcement, motivational interviewing and motivational enhancement therapy, family approaches, which are particularly useful and with good evidence with regard to adolescents with drug use disorders, and mutual help groups as examples. And then there is the whole, the big and strong efforts in pharmacological interventions that are at the disposal of everybody. Of course, there are medication for withdrawal management, but one of the most important things is in the case of dependence disorders, on drug use disorders with regard to opioids, is maintenance or substitution, as it's sometimes called, with opioid agonists such as methadone, buprenorphine and naloxone, and that is one of the most recognized, and as we have seen, not only recognized but used and effective kind of therapies worldwide in the case of opioids, and also because it helps a lot in terms of preventing health and social consequences. There is also options for a minority of people with opioid use disorders that are very motivated to use antagonist treatment with naltrexone. Unfortunately, we don't have that kind of really great option for the treatment of disorders by psychostimulants and cannabis. We have recently made a systematic review of the evidence of all of the pharmacological options, pharmacological therapies of maintenance that do exist for stimulants. There are some initial indication, and but not enough science, nothing as the strong science that is behind methadone and buprenorphine. So this is really a place where we are hoping to stimulate more science and more trials, because it is a growing problem, and we just don't have that amazing tools that we have for opioid dependence like we have in methadone and buprenorphine. Of course, using methadone, buprenorphine helps already a lot with preventing overdose, but there is a lot that can be done in identifying and managing overdose that unfortunately can occur even in the best treatment system by providing naloxone, but not only to first responders, right? Also to peers, to families. It's really a safe medication, minimal training we have, and feasible also in low middle income countries. We have done a study very recently in Central Asia, so it should be promoted in the standard and should be taken up more. And of course, following therapy and treatment, there will be a need to continue on long term and to try and maintain contact with the health and social services. This will, of course, vary according to the individual. The important thing is that the system is ready to recognize that relapse can happen. It's not tragic. Is not a moral failure, is not a failure of anybody. It can happen, it needs to be managed, and people can just be supported to protect their health and get on with their lives. And therefore, that's where the system of recovery management comes in. And there will be a need, of course, of treatment of co-occurring conditions. I don't speak so much about co-occurring infectious diseases because Monica will take over that one very much. But there are other physical health conditions that affect the health of people who use drugs and people with drug use disorder. And of course, many mental health conditions co-occurring, for which we are really basing ourselves. We're taking the guidance from our colleagues in the World Health Organization and their global program on mental health intervention guides. But they are included in the standards. And the standards also promotes, and we can talk a bit more, maybe in the question and answer session, specific intervention for people that have special needs. And I will just mention some of these populations that find themselves in very vulnerable circumstances and therefore need specialized care. For example, women, but also people in prison settings, people in contact with the criminal justice systems, and adolescents, to just mention a few. So what now? We have the standards, and now we are starting thinking about how to use them. And one of the things that is still under development and that we are thinking about is to use the standards to develop, to help member states to develop mechanism to assure the quality of services and treatment. We have started some pilots in Afghanistan and Nigeria. Let's see how those goes. We are introducing them in Latin America, where COPOLAD, some of you might be familiar with this European Latin American cooperation program, had already done some good work, very strong work on quality assurance. So we are building on that, and the idea will be to develop sort of like you see on the screen, to develop criteria on which services can be assessed to induce a virtuous and continuous cycle of improvement. And I'm really looking forward to the question and answer session in terms of other ideas that might be out there in terms of using the standards at country level and really to help improve drug treatment systems and services. And with this, I conclude. I thank you. I am at your disposal for answering questions, hearing your ideas, and these are the contact details of my colleague Anya. Please forgive me, I forgot to put mine, but I will put them in the chat. And other than that, I give back the floor to Jamie and Mirella. Thank you. I hope I didn't go too much overboard. I think I was okay.
Over to you, Mirella. Thanks, Giovanna.
I'm stopping the sharing.
Yeah.
Okay.
Sorry, Jamie, I thought you were continuing. Monica, yes, actually, Giovanna spoke a bit more than the time, but the floor is all yours.
Sorry.
Yeah, I'm here. Maybe Sarah can put up the presentation.
Give me a second to figure out the sharing.
So while Sarah is preparing the presentation, let me introduce myself. My name is Monica Ciupagea. I'm expert on drug use and HIV in the HIV section of UNODC. I have to warn you that I don't have these impressive technical skills that Giovanna just put on display. I don't know how to use that that interactive slides, but if you will invite me again, I promise I will learn. So as soon as the presentation is up, I can start talking about the slides that you will see. But in the meantime, I need to let you know that UNODC is one of the co-sponsors of the UNAIDS, one of the 11 co-sponsors of the UNAIDS. And as part of this, we are the convening agency for HIV prevention, treatment, and care among people who use drugs and among people in prison, two of the key populations that are currently most affected by the HIV epidemic. I'm not sure if you can hear me. I don't see the presentation yet.
No, not yet. The slides aren't up. I think Sarah, do you want me to try and share it from this side?
That would be awesome, because some computers see Zoom as a threat and doesn't like sharing the screen with them.
Okay.
The second, yes,
Now
I can see it. Yes.
Okay. So
thank you very much.
To you, Monica.
So we can move. I already introduced myself. I need to let you know that unfortunately I won't be able to stay with you until the end of the meeting, but we have today with us my colleague, the chief of our section, Fariba Soltani, who will be kind enough to take the questions at the end. So Sarah, if we can move at the next slide. So as I mentioned, we are the convening agency for drug use, for people who use drugs and people in prisons. We are talking about 11 million people who are injecting drugs and about 11 million people who are in and out of prison at every given time. And as you can see, the prevalence of HIV, but not only HIV, hepatitis and tuberculosis as well, are very high in these groups. And probably you are familiar with these figures. The data that we have from last year show that 62% of the new infections are HIV infections are among people who are among the key populations, and among people who use drugs actually is 10%. Can we move to the next slide? So talking about the guidance that we issued, the first document that I want to talk about is the target setting guide. This was developed first in 2009 and then updated in 2012. Is described the comprehensive package of 9 interventions that are recommended and endorsed by all the UN fora in preventing HIV among people who inject drugs. And you can see them on the screen. Recently, we are adding, I mean, not recently, more and more we are adding overdose prevention and treatment as another intervention, because, you know, people have to be first alive in order to effectively prevent HIV and hepatitis and tuberculosis among this group. You will see here on the screen two other publications. One is the consolidated guideline that WHO, in collaboration with other UN agencies, developed in the meantime, and it's more extended, but is based on the same recommendation. And also a guidance that was developed by UNODC in collaboration with International Network of People Who Use Drugs, is on how to implement these interventions with the community. So not for or among, but with the community. Something that, you know, you stressed very well before when you were talking about the involvement of the community in the delivering of treatment services, but obviously not only treatment services. Could we move to the next slide? The next slide, it's showing a series of publications that we are developing for addressing the needs of women who use drugs. I have to tell you that this is an initiative that was initiated in the UNODC Civil Society Group on Drug Use and HIV. This is an informal body that is functioning for 8 years already, since 2013. And we work together on many initiatives. We have a plan every year, and focusing on the needs of women who inject and women who use drugs was one of the priority of this group. So as a result, we developed a policy brief, a practical guide, and most recently, we developed a publication on prevention of the transmission of mother to child of HIV, hepatitis B, and syphilis. The policy brief and the practical guide inspired the CND resolution. The PMTCT guide actually was based on a resolution that was approved in the CND 2 years ago. Sorry. Could we move to the next slide? The publications are adapting the comprehensive package of HIV prevention among people who use drugs to the needs of women. And if you go to our website and you see our publications, you can read more about what are the interventions and how they can be adapted to meet the needs of the women. So let's move to the next slide. This is another initiative that was initiated in the civil society group. It's a guidance on HIV and hepatitis prevention, treatment, and care among people who use stimulant drugs. It describes 8 interventions. Sorry, there is something that is cutting my voice. Just give me a second. Okay, let's try again. So as you can see, it describes 8 interventions. And based on this technical guide, we developed a training package for the 3 substances used: amphetamine type stimulants, cocaine, and new psychoactive substances. And we managed to do a lot of trainings face-to-face before the pandemic. Now we are moving this capacity building exercise online, and very soon we will have a training package available online. Let's move to the next slide. I wanted to bring to your attention also publications that we did on building the capacity of law enforcement to support the harm reduction interventions. We have a training manual for law enforcement and civil society. And here also we train more than 4,000 police officers and 400 civil society organizations and also decision makers on how to improve their work together. And there is also a guidance for civil society on how to work with law enforcement. Next slide, please. We have, of course, very many publications on how to work on HIV prevention, treatment, and care in prison. I'm just going to highlight the most important ones. We recently reviewed the comprehensive package of interventions for prison. It's one of our newest publications. There is also, following a crime commission resolution, guidance on prevention from mother to child transmission. And there is, of course, a publication on the United Nations standards of minimum rules for treatment of prisoners, what we call the Mandela rules. Could we move to the next slide? We have a dedicated website for COVID and HIV prevention, treatment, and care among people who use drugs and people in prisons. You can visit. I strongly encourage you to go and visit the website, and there you can find our newest publication on ensuring the continuity and sustainability of harm reduction and prison services during the COVID pandemic. If we can move to the next slide. So here you can see the guidance developed for harm reduction services. I have to tell you that they are translated and in all languages of our 24 high priority countries, and they were also adapted at the local context. And if we move to the next slide, you can see the similar publications that were developed for prison, as well as common joint statement and positions on HIV prevention services in prison during the COVID time. To support the technical guidance, we also developed a series of webinars for the service providers and also for decision makers, making sure that we keep alive the dialogue on how to ensure, as I said, the continuity and sustainability of services during the COVID pandemic. So I will stop here. The last slide is just to thank you. And I have to apologize first for my voice and then for the sound of this presentation, but I'm delivering this presentation in unusual circumstances for me. Thank you.
Thank you so much, Monica. You can go and have a nice drink of water now. But thank you so much for the presentation and for introducing those important documents as well. And I don't know if it's possible, maybe Sarah or Fariba, to put into the chat box some of the contact details as well, in case people have any kind of specific follow-up. So as I said, please do submit your questions in the Q&A box, but for now, it gives me great pleasure to give the floor to Devon de Koker from STAND in South Africa. As we often do, the Vienna NGO Committee did an open call to invite applicants to speak at this webinar. And Devon submitted a wonderful kind of abstract to talk about the work that Stand are doing, and to really to emphasize the integration point, which I think is a really important message from this webinar. So yeah, Devon, please, over to you.
Thank you so much, Jamie. I'm just trying to share my screen.
Hi, Devon. We could see it if you do enable editing, and then press the slideshow button at the top, and it should come through as a solid slide for us.
Yeah, I'm just struggling to do so. Yeah. Are you able to see the slideshow now? Awesome. So good afternoon, colleagues from Cape Town, South Africa. So this afternoon, I am going to speak to you about the paradigm shift in substance use disorder treatment in South Africa, and specifically based on the international standards as presented by Giovanna earlier. So first of all, I think it's just very important that I give you an overview of SUD treatment in a South African context. And I need to mention that in terms of the history in South Africa, we have a very traditional SUD treatment approach in South Africa. And the focus has been for many years on abstinence, on an abstinence-based approach. So in essence, I believe in professional treatment settings where clients are encouraged to strive for complete abstinence. So harm reduction for many years was a word that didn't even exist within the context of South Africa. And so inpatient treatment has been the traditional form of treatment and also the preferred form of treatment in South Africa for various reasons, which some are of the following. So traditionally understood form of treatment from within community settings. So it's almost like communities understood inpatient treatment as the only form of treatment in South Africa. And then we have very few outpatient community-based treatment services. So there's more inpatient treatment services as opposed to outpatient treatment services in South Africa. Very important, there's also lack of participation of family members or significant others. So in essence, the perception of substance misuse within the family context. So families within the context of South Africa very much understand that a person with an SUD needs to go to inpatient treatment services, and the concept of both harm reduction and community-based services are very foreign concepts still within South Africa. And then we are really sitting with severe challenges within our country. So with specific reference to the development and implementation of the full continuum of care, with specific reference to aftercare and reintegration services, linkage to community resources. So there's still very much fragmentation and social exclusion from an SUD perspective. And then the significant, we really have a significant shortage of professionals who specialize in SUD treatment services in South Africa. So within South Africa, you mostly get social workers that specialize in child protection and generic social work services, registered counselors and psychologists that specializes in generic practice and not specifically in SUD treatment. We also have vast rural regions with no professional SUD services whatsoever. And then in South Africa, the metropolitan areas are significantly more resourced. Rural SUD situations are becoming more dire within South Africa. South Africa, I just think it's very important for us to understand that South Africa is still a developing country with a very challenging socio-economic context. And that basically means that we are sitting with high levels of poverty, marginalization, social exclusion, social problems, for instance, gangsterism, unemployment, crime, gender-based violence, and dysfunctional families, to name a few. There is also a severe disconnection between pivotal services such as social development, health, and related key services. So we are sitting with high levels of fragmentation from a substance use disorder service perspective. Then there's no platform or opportunities to implement an effective continuum of care in SUD services in the country. The deep-rootedness of social problems, particularly poverty, and the lack of effective policy and service responses to poverty makes the planning and the implementation of quality SUD services challenging. So we are really rendering SUD services within a very challenging socio-economic context currently in South Africa. I'm just going to give an overview of our organization's community-based treatment service, and that this community-based or CBT service can really mean a paradigm shift in terms of SUD services within South Africa. So the STAND community-based treatment service is a fully mobilized treatment service delivered in each community setting as opposed to clients traveling to one specific venue. So that's just very important to take cognizance of due to the high levels of poverty, unemployment, etc. We decided to fully mobilize the treatment service and plant it right in the heart of the community as opposed to clients that need to travel very far to access services. Then the treatment service provides for a far greater involvement of the family unit from day one with the consent of the client. Then clinically, we just use clinically approved instruments, for instance, the Maudsley assessment tool, the assist and the audit screening tools, amongst others. The treatment is 100% individualized, it's trauma-informed, it actively aims to build personal empowerment and capacity following a strength-based approach. The STAND CBT service incorporates the principles of integral recovery. So in essence, exposing the client to natural and enjoyable activities. So this really ensures a balanced approach in treatment. So what that means is that we don't only focus on therapeutic work or professional counseling service, but we also expose the client to recreational activities, and we also incorporate contingency management to balance the therapeutic work or the therapeutic services we render in the treatment program. And then it's very important to mention that the STAND CBT service incorporates all principles of harm reduction based on the unique needs of the client. So we don't follow an abstinence-based approach at all. We purely focus on a harm reduction approach based on the individual treatment goals of the clients. The treatment, in terms of treatment success, we determine that on the unique goals of the client. So we don't set treatment goals for the client. That is completely individualized. And in terms of treatment completion, that's determined by treatment goals. And the extension, we also grant extension when necessary. Extensions include services to the family and significant others or of the primary clients. So if there's still specific service needs pertaining to the significant others of the primary client, we include them in terms of treatment extension. Home visits are conducted where significant others cannot reach the central community treatment site in the community, and the CBT service is really rendered in the heart of the community, so it's 100% community mobilized. Service incorporate, or actually all services incorporate overall health and mental health services in a multidisciplinary team approach. So it's incorporating governmental services. I think the international standard speaks about a one-stop shop approach, and that is really what we try to implement effectively within our program. The STAND CBT service is evidence-based, it's trauma-informed, gender-centric, culture and context background sensitive, in addition to focusing on sustained recovery management, developing recovery capital by building on the strengths of the client and the family unit. So within South Africa, there's also not very high recovery capital amongst our clients, and we really seek to enhance the recovery or to develop the recovery capital as we render services within our treatment program. So in terms of the international standards, and earlier on I spoke about a paradigm shift. So what we realized in our treatment program within South Africa is that the standards can assist with a paradigm shift in SUD treatment in South Africa when implemented effectively. It really assists us with higher client and family retention by implementing the norms and standards. And then the standards also assist us with a higher probability of reduced substance use, as well as a reduction in adverse behaviors associated with SUDs through the implementation of the standards in an effective manner. The standards assist in ensuring ethical practice in SUD treatment, and that is what we found in our treatment program. And I think when you really are focused, when you really focus on implementing the standards in an effective manner, you will realize that the standards really advocate for high client care, and that is what we are focused on in our treatment program. The standards assist in defining key population groups and formulating interventions that specifically suit their unique needs. So for instance, women, adolescents, and then a thing that's very real within South Africa is farm workers in a rural South African context. And then the norms or a paradigm shift in SUD treatment is possible if the norms and standards are followed correctly. That is what we found in our treatment program in South Africa, rendering services according to the norms and standards with a harm reduction approach in accordance with the unique treatment needs of the client with an individualized strategy can be the vehicle that moves South Africa towards a paradigm shift in the treatment of substance use disorders. And what we found is that we really need a paradigm shift in the treatment of substance use disorders in South Africa due to our range of challenges that we experience. We are moving towards a point where legislation and key policies include harm reduction concepts and strategies. So previously in our country, the overarching legislation pertaining to SUDs and policies were based purely on an abstinence-based approach. And so that is currently in the process of being changed in South Africa. So our overarching legislation and policies currently speaks to a harm reduction approach. So it's currently, or what I want to say is that it's really possible to ensure or to embark on a paradigm shift in terms of SUD treatment in South Africa. So right now is a perfect opportunity to give impetus to a paradigm shift in the treatment of SUDs in South Africa, and it is possible. Colleagues, I thank you.
Thank you so much, Devon. That was wonderful. And yeah, for those who are asking, as we've said, we will be sharing the slides as well for everybody, as well as the recording. So thank you so much, Devon. So we now have some time for questions, which was, as I said, was always the hope that we would have today, some good time for questions. So you can all look at the Q&A box to see what questions have been submitted. And actually, Giovanna has already been typing answers to some of those questions. So thank you for doing that. And you can see those, if you look at the top of the Q&A box, you'll see which ones are open, which ones are answered. So you can see some of those responses already. And I'll just take, there's still time to submit questions, but I'll start with the ones that are there, because they're the ones that have come in already. So I think the first one, Giovanna, really relates to the treatment standards. It's a comment from Ruth Bergin from the Women's Harm Reduction International Network. She was surprised that naltrexone is included. She says that the evidence is poor and application in practice is not infrequently harmful. She's asking, why is naltrexone included? I'm assuming, yeah, I'll just hand over to you on that one.
Well, we included it following also what are the recommendations included in the guidelines developed by WHO, and it's true that the evidence more than poor is limited. It limits the efficacy of the use of naltrexone to a very specific kind of person who use drugs and person with drug use disorder, and these people are a minority, and as such is mentioned in the you will see in the standards. that it can be useful in cases of highly motivated patients and that are very highly motivated by themselves and in their socioeconomic environment to abstinence. It's not recommended as a first line or as in wide application, but for a minority of patients it has been found useful, and as such is mentioned as one of the possibilities that are at the disposal of treatment services and systems. And I will add just because there was a small question which I replied in writing, and at least for the treatment standards, I've not presented things in order of effectiveness. We present things in order of just presenting the entire range. And I wanted to clarify that. Thank you.
Yeah, okay. Thank you so much, Giovanna. That's great. We've had another question submitted in Russian, so I'm hoping that Google...
that I could not read, I'm sorry.
No, I'm hoping that Google Translate isn't about to let me down, but okay. I believe the question is there a mechanism to react when a national clinical treatment protocol, or basically national practice, does not comply with the recommendations from UNODC, WHO, and UNAIDS? And I guess this is really a question, Giovanna, you can go first, but also Fariba, it'd be good to hear from you. Basically, what is the course of action when an NGO partner in a country sees that what's going on in their country doesn't align with the recommendations that we've just heard from today? Giovanna.
Yeah, well, I mean, that's the $1 million question, right? Because, and it's not only on treatment, but also in prevention, and also Fariba will come in from the point of view of HIV prevention, treatment, and care for people who use drugs. And I think that, I hesitate to say it, but in the end, the answer is collaboration and cooperation, and I explain. There are different actors at national level, and different actors can do different things. And the important thing is that we try to coordinate the action. As international organization, we are governed by member states. We are governed by the very governments that might be behind the practice that is not in line with the standards. It's extremely difficult for us to take a confrontational approach publicly, but we can influence behind the scene. And what I've seen functioning better is that if pressure comes in different ways, maybe coordinated with civil society partners, to change that practice. And that is another reason why we are trying to think about mechanism to not only talk about the standards, right, but to really engage member states slowly in that continuous mechanism to assure quality. And maybe the first time we will manage to improve a little bit, but then another time will be more and more and more. I am cognizant of the fact that we are talking about sometimes about situations that are very urgent indeed, because services are not available, people are dying, or services are compulsory, and there are human rights violations, and we just need to keep on pushing. And I've taken great heart from Devon's presentation to see how things can change even very rapidly, and if we coordinate with each other. Fariba, I'm sure you can add some words of inspirations there from your great experience.
Thank you, Giovanna. Thank you, Jamie, and good morning, good afternoon to everyone. My name is Fariba Soltani. My colleague Monica, who is our lead on drugs and HIV, she had to leave for an urgent appointment, so I'm taking over to answer as best of my abilities what some of the issues that are raised regarding harm reduction and the work that we are doing at UNODC on HIV among people who use drugs, and we also cover the prisons. If there is any, issues raised, as Giovanna said, what we do, first of all, we go through our country teams. We have colleagues on the ground. It's not only us sitting here in Vienna. And actually, most of the work that we have both mentioned is being implemented by our extensive team in the countries. And they are the ones who are really driving our work at the country level. What we do here, our role is more advocacy and development on coordination and development of the technical guides. And what we do, as Monica mentioned earlier on, whatever we do as a co-sponsor of UNAIDS, we do together with WHO and our colleagues in UNAIDS and other co-sponsors, depending on what is the issue that comes up. So when we do get a complaint from one of the countries, we immediately contact our colleagues at the country level to really see what is going on, to see how we can help, to start collaboration with the center to provide the guidances, the international standards and guidances that are available. And we also inform the country teams. We seek assistance from our colleagues with UNAIDS and WHO, because when you approach things from different agency mandated areas, I think it makes it gives us a stronger voice as the UN. So we try our best, but as Giovanna mentioned, we are our mandates are driven by the member states. So maybe we can't act as quickly and as efficiently as we are expected to by our civil society partners at some points. But I think we play an important role in ensuring that discussions are started and best practices are showcased to the CSO where the problem is, or to the service where the problem is arising. Thank you.
Thank you. No, thank you, Fariba. And I think, I think it is a useful point to, to put it back on civil society as well, because part of our role as civil society is to highlight where these things are not aligned, and, to use the guidance to monitor and review the services and the programs that we have at the national level. So, that's something that, that's why these webinars are useful, because you've now all met Giovanna, you've now all met Fariba, you've now all met Monica. So, and you've got contact details in the chat, and these are the avenues that we should take. And, that's in that sense, these standards and the guidance, they are advocacy tools for us to advocate for better services. And they're not the only ones. You also now have the UN Common Position on drug policy, which also contains a lot of strong language and guidance in this direction and refers to the standards. So yeah, I think that's it's a call really to civil society to do that work and to highlight where those problems exist. Okay, so moving on, we have a question from Yeti in Malaysia. She's asking, are there any recommendations from UNODC to member states for key performance indicators or for M&E monitoring and evaluation to measure the success of rehab programs? Now, I know for the harm reduction part for Reba, the technical guide that we presented is a target setting guide, so it has targets and KPIs. But on treatment, is there anything there for rehab? Is there anything recommended for how do you measure the success of a rehab program?
Yeah, not yet. And so in the standards, I present, there was a slide where I said, treatment should be effective along a range of measures. And that is as far as the standards go in setting that broader definition of what a positive treatment outcome is, and try to move away from just abstinence and really introduce the health and all of the dimensions of health and well-being that are needed to really see whether treatment is effective or not. And that's for me on the to-do list. in the sense that at the moment I was more preoccupied with that quality cycle and starting to think and develop something solid there. But of course, this is an excellent and very relevant question, and it's something that we need to address, because it would be very useful in moving the dialogue forward, also with member states, as I think the question itself was mentioning. You know, with member states that report amazing success in terms of treatment interventions that we know are not according to standards, right? And we need to find a way to have that data in a way that then we can say, look, it's not really how you report. Let's do something about that.
Yeah. And there's always, you know, there's always kind of unintended consequences to how you report. So I remember in the UK, we had a system where treatment was considered a success if you did not represent, if a client did not come back into treatment within 6 months. That was considered success.
Yeah.
And the unintended consequence was that drug services were more nervous about taking on clients who were less likely to achieve that goal.
Exactly.
So yeah, no, I think that's a really useful, that's great to know, Giovanna, and that's obviously a really important piece of the puzzle to come.
And indeed, that's exactly what I was going to say. You know, the other problem is to set up success in a way that does not penalize the service, and so that, you know, you're providing a service, and as soon as you stop, I mean, that's normal that there will be some relapse and so on, and this should not come up as an unsuccess. In fact, retention in the service should be the real one of the real indicators. But it's an interesting but not easy battle there.
Yeah. No, thank you very much. I mean, Devon, I'm conscious as well, you know, we really want to, we've learned so much from the South Africa experience you presented, and you know, please do let me know if you want to chime in on any of these questions as well. But you know, from your side, Devon, what are the indicators being used in South Africa,
for example,
on this? You know, just, you know, how is success? You know, how is that defined from your perspective?
So basically, we don't have any formal indicators at this point of time, but in terms of treatment success, we measure that by the objective set by the client, him or herself. So in terms of harm reduction approach, we'll usually see what is the exact goal the client, objective the client have set, and then we measure treatment success based on that, and not abstinence at all. So that is basically then in terms of continuous substance use in a harm reduction perspective, and also adverse behavior associated with the SUD. Yeah.
Okay, brilliant. Thank you. So let me move on. I think the next question's one for Fariba to take for us. We've got a question from Eric in Costa Rica, who's asking why in Latin America, and especially Central America, why do the harm reduction recommendations, why are they not so robust by UNODC? So I don't know exactly what that means, but you know, I guess there's maybe a sense that they're not being promoted as much in that part of the world as maybe Eastern Europe or Asia or Africa.
Yeah. Thank you for that question. It's a very good question. And as you know, I mean, our presence, as I mentioned, we have presence on the ground, and our staff on the ground are the ones who are promoting the work on harm reduction. And this is all dependent on funding, whether we have funding to put somebody on the ground. And we had a funding cut to our program in 2016, which actually resulted in us reducing the number of staff that we could actually keep on our team. And in order to work more constructively and efficiently, we have selected high priority countries together with our CSO partners. We have selected these high priority countries in different regions where we are focusing our efforts And in Latin America, Argentina and Brazil are a part of our high priority countries. And we did have staff in these two countries, and we were doing very large programs. But as I mentioned, due to different issues, we have lost our staff. But I'm glad to inform you that we have started more engagement with Latin America. We have a consultant now working who used to be our staff, who is organizing webinars on HIV and COVID related issues now in Latin America. This should be coming up very soon. In the next couple of weeks, we will organize these webinars for Latin America, and we hope to increase the amount of work that we can do and the advocacy efforts that we can manage to do regarding harm reduction in that region. I hope that answers some of the questions. Thank you.
No, thank you. And Eric did follow up with another point to say that, one of the greatest challenges they're facing is that, the focus is very much on abstinence, and any other goal that a client might have is proving to generate stigma. Giovanna, did you want to come in on this, or did you have your finger up yet?
And very briefly, I mean, the other issue that I was trying to allude to in my presentation is also the fact that in Latin America, a lot of the use is around stimulants. And for stimulants, we just don't have that pharmacotherapy, that substitution treatment like we have for opioids with methadone and buprenorphine. And that's why I was saying there are some indications of possible medication that could be used in a maintenance therapy that would help no end. The evidence is just too little yet, and we've been trying forever to pull together a trial that is larger and more solid in different countries to start generating that kind of evidence that was behind, that made made methadone and buprenorphine. So that's another thing for the to-do list, where I'm hoping that we can join forces in really advocating for more resources, more research on pharmacotherapy and maintenance for stimulant use disorders.
Fantastic, thank you, Giovanna. So one last question, just because we've got we're nearly finished, but one last question that's come in is from Juma in Tanzania. And she's asking, what does recovery capital contain? What do we mean when we talk about recovery capital? I don't know if that's a phrase that's a phrase in the UK, for example, that we did see a lot in the policy, meaning that, someone's own kind of situation and their own kind of coping mechanisms and their social surroundings and, all those environmental things that give them the capacity to address any drug-related problems they may have. So is that, I guess, first of all, is that a term that you're familiar with? Is it a term that's kind of placed? Is that something you use when you talk about the standards? And if so, what's your understanding of it? So Giovanna, I don't know, Devon, is this something in South Africa as well? Is this language that's used in South Africa?
In terms of a South African perspective, it's relatively new, but because we try to align, especially with our first world countries in the global direction, we nowadays we also talk about recovery capital, and especially when we train on SUDs, we introduce professionals to the term of recovery capital.
Okay.
We are way behind on that. For us, the important thing is that treatment and therefore also the recovery process needs to be individualized and needs to take into account the entire history and present situation of the person and be tailored to that. And there will be people that have less recovery capitals, less resources, either in themselves or in their immediate socioeconomic circumstances, and they will need more support. And those are the people that it's really our call to be there for. And so thank you for introducing me to a new term. I think that while not explicitly, the standards do take into account this by recommending absolutely voluntary and individualized approaches to treatment and recovery.
Yeah, no, I think, and that for me is the exciting potential of that language, is that it is person-centered, and it takes us away from this idea that everyone should have the same treatment, you know, and that actually it really should be. And as long as it's done in a way that no one is ever excluded because they don't have enough capital, as long as that's never the goal, exactly. Then I think it can be a very positive force, in, you know, a good narrative to use. Okay, so I just want to wrap things up. I'll hand over to Mirella for her kind of final remarks as well. But just to say from my side, you know, a big thank you to Fariba, Monica, Giovanna, and Mirella. You know, to all the UNODC colleagues for helping make this happen today. And also to Devon. Did I see in the chat, Devon, that it's your birthday today?
Yes.
Well, there you go. What a great way to spend your birthday with us.
Happy birthday, Devon.
Happy birthday, Devon. Happy birthday.
Thank you so much, colleagues.
This is dedication for you.
I wasn't going to let that go uncommented. But yeah, so thank you to all of you for, you know, all of our panel today, but also huge thank you to UNODC Civil Society Unit, to the US government for helping support this program of work, to Sarah Perker, who's our VNGOC project manager, who makes all of this happen, and also to our translators as well. And crucially, yeah, to all of you for joining. You know, we had close to 200 participants almost all the way through. So thank you all so much. And Mirella, over to you.
Thank you, Jamie. Happy birthday again, Devon, and thank you for joining us on your birthday. Thanks to Fariba, Monica, and Giovanna. I just want to correct Jamie, this webinar is not funded by the US, but I just thanked all our donors in general, so I wanted to make sure that there is no confusion. Also, I want to take this opportunity to promote our joint NGO marketplace. This is our tool to have an overview of all the NGOs working in the field of drugs. My colleague Billy will put the link, I think, to the marketplace, so that we make sure that those who are not already members are also take this opportunity to go and see and join in, and maybe they can exchange their expertise, because this is what we are really. I mean, UNODC, we are here to facilitate your work and ensure that there is good interaction with the member states, but also among you, if possible, as civil society. And I think our next appointment will be more or less in 3 weeks with the Commission on Narcotic Drugs that will start exceptionally this year in April, from 12 to 16 April. So until then, I wish to everybody to be safe and enjoy what is possibly enjoyable these days. Thanks again, Sarah, who's in the background, and my colleagues. Bye now.
Bye, thanks.
Thank you, bye-bye.